Hello, everybody. This is Chapter 46, the Assessment and Management of Patients with Diabetes. And I'm Rebecca Rowe, your adjunct instructor for this particular course. And I wanted to take some time today to thank you for your patience and understanding in having me do these courses for you this semester. It's been a real joy to do it, and I hope you've gotten something from it. I really appreciate it. So with no further ado, we'll get started with diabetes. This is a complex topic with lots of things and lots of constant updates on the topic, and we're making a lot of innovative strides in the management of patients with diabetes, so I hope that we will learn some things together as we go along. So diabetes is an illness caused by insulin and blood sugar imbalance. It is a chronic disease, and it occurs when the pancreas is no longer able to make insulin or when the body cannot make good use of insulin it produces. It affects a great many people, around 37 million people in the United States, and about 1/3 of those cases that we see sometimes come in undiagnosed. Approximately 96 million of patients are diagnosed with prediabetes, and the prevalence of these numbers will continue to rise. It's newly diagnosed adults by 1.7 million per year. Could be 1 in 3 adults that could have diabetes by the year 2050 is what's prognosticated in their current research. CDC keeps a lot of statistics on diabetes management because it's one of the leading causes of death and morbidity and mortality in this country and worldwide as well. The worldwide statistics from the International Diabetes Foundations in 2022 says that over 535 million in the world live with diabetes, and that will grow in numbers exponentially in low and middle income countries. So it's something that we all have to deal with. So there's classifications of diabetes, but the most common are in green in this particular slide. The most common are type 1 diabetes, type 2 diabetes, and gestational diabetes. And the LADA, or the latent autoimmune diabetes of adulthood, is on the rise. And so we're going to talk a little bit in more detail about that because I want you all to be aware of where the latest research is on that, because it is a recent finding within the last 20 to 25 years. And so I think it's really important that you guys understand the classification. And there's many of them. So there's many causes. So it's important to know that whether type 1 or 2 or some other classification, what they are, and that it will affect people of all ages, genders, and sex. So table 46.1 in your book, you need to look at that and make sure. But here I've listed kind of things to help me organize how the percentage of cases that we see. Of course, type 2 diabetes is 90 to 95% of the cases that are diagnosed. And so you'll see a lot of those cases. In fact, some in our audience today probably have diabetes, so it's not uncommon. So type 1 diabetes is a chronic lifelong condition, and it can lead to serious health problems if it's not adequately managed. And if it's not adequately managed, it can shorten your lifespan by quite a few years. It usually starts in childhood or early, adolescence, but it can also appear in adults as well. The type 2 diabetes is the most commonly diagnosed. It is mostly related to obesity. And it is commonly diagnosed with patients that are over 30. People over 30, the pancreas produces less insulin, the body becomes resistant to it. You'll see this metabolic syndrome with the increased blood pressure, increased cholesterol, and those patients that are overweight. And you can see there that some of the situations that are causative factors in type 2 diabetes have to do with obesity, heredity, and environmental issues. Gestational diabetes occurs in about 8.3% of all pregnancies. That number is growing. It is in the age group of childbearing females. You see hyperglycemia during pregnancy. One of the clinical characteristics is for mothers have abnormally large babies, and that's macrosomia. The cause of that is hormones from the placenta that inhibit the action of insulin. This usually starts occurring within the second and third trimester. We'll go into a lot of greater detail on this particular classification of diabetes, but I want you to understand that if someone has gestational diabetes during pregnancy, they have a higher propensity to develop type 2 diabetes later in life, and so does their child. So that is a pretty interesting finding. The LADA is a latent autoimmune diabetes of adulthood. It happens in about 10% of those that are diagnosed with type 2 diabetes, and it is somewhat of a combination of type 1 and type 2 diabetes. Therefore, you may see it's called type 1.5 diabetes. It occurs in patients that are over the age of 30. And what it does is it shows that you have uncontrolled hyperglycemia or high blood glucose, and there's no metabolic syndrome, and you have a normal BMI. And what that is you have autoimmune problems, usually with thyroid, arthritis, some other type of thing that causes you to have an autoimmune disorder like lupus. It does not respond to your disease, does not respond to oral anti-diabetics. And so it's a pretty interesting and difficult to diagnose classification of diabetes, and we'll go into that in greater detail. MODY or MODY is mature onset diabetes of the young. It usually occurs in folks that are less than 25 years of age. This is a genetic mutation. It can occur early on, and in some children it can occur on the alpha. It can occur and go away. And so there's 4 different types of MODY, and so the treatment ranges from oral antidiabetics to insulin to no treatment at all. So it just depends on what kind you're diagnosed with, and we won't go too much into detail of that. Just wanted to let you know that that's out there. And then type 3C diabetics are those of any age that have had damage to their pancreas that triggers the limited insulin usage, whether that is from cancer, tumor, pancreatitis, surgery to the pancreas, traumatic accidents, automobile accidents, gunshot wounds, whatever the cause, there is a problem with the pancreas. It requires the patient to take insulin administration every day. You also have the same risks with the type 1 diabetic, where you have a shorter lifespan and you run the risk of DKA. So those are the classifications that we're basically going to look at in some detail. So type 1 diabetics and type 2 diabetes are a little bit different. Type 1 diabetics, the pancreas stop producing insulin altogether. And then type 2 diabetics, the cells become resistant to the effects of insulin. So there is some differences in that. And so I want you to be aware about that. You can't talk about diabetes without talking about insulin, because it is what helps to do many things with glucose and with fats and glucose and storage of those glucose and glycogen in the muscle, and using the liver to help transport these things, and the release of the hormones that help with blood sugar and fat storage. So in the last lecture, the biliary system, we specifically talked about the pancreas, and we discussed that one of the pancreatic cells, the beta cells, secrete the hormone insulin. And the lack of insulin or the resistance of it prohibits its normal actions. And the normal actions of insulin is to transport and metabolize glucose for energy, and to stimulate storage in the liver and muscles as glycogen, and to signal the liver to stop the release of glucose, and enhance the storage of dietary fat in the adipose tissue, and to accelerate the transport of amino acids into the cells, which, as you know, amino acids are the building blocks of life. Insulin also inhibits the breakdown of stored glucose and protein and fat. And I want you to think about insulin from the hormonal situation as the body's messenger to tell the body to use its choices, to either use the food for energy that it's ingested, or to store it, or use it however it needs. Well, let's talk about type 1 diabetes for a minute. So type 1 the normal system goes wrong. There's no messenger. There's no insulin hormone being produced, or there's a very limited amount. Of course, food is ingested in the body. The body's not recognizing it, so it is not stored. It just circulates around and around and around, and it's not either used for either of those choices of energy or storage. So it finally ends up in the kidneys, where the kidneys recognize the blood is turning into maple syrup. And so this is why you get the symptoms of thirst and polyuria and all that, because what happens is the kidneys start adding more water to the urine to dilute it, because it would be extremely painful to urinate crystallized urine. And so you dilute the blood. These lead to the classic symptoms of your thirst, the polydipsia, polyphagia, and polyuria, and you end up not being able to use the food. So there's no storage of fat. And so you'll see an immediate loss of weight in the type 1 diabetic. And that's what usually happens. In order to replicate the normal insulin process, insulin must be taken exogenously or outside the body, and it has to be taken during the day, several times a day, in time with meals or at bedtime, to compensate and to cover the amount of glucose that the body produces. So type 1 diabetes affects about 5 to 10% of adults with diabetes, and it most frequently is diagnosed in the early ages of childhood to adolescence and then beyond. Now, like I said, type 1 diabetes is getting better to manage, and so people are living a little bit longer. But when you compare the ages of those with type 1 diabetes and those folks who do not have type 1 diabetes or any diabetes at all, you're looking at a shortage of lifespan by anywhere from 6 to 14 years. So it does impact from other situations where the sugar has an effect on the organ systems of the body. And we'll talk about that too in a minute. So type 2 diabetes is your insulin resistant and a little bit of the impaired insulin secretion. This affects about 95% of adults with diabetes over the age of 30, and you're starting to see an increase of that percentage in younger and younger ages. This is related to obesity, sedentary lifestyle, and heredity. There is a slow progressive glucose intolerance, and this may grow undetected for many, many years. So the process usually shows the pancreas functions normally for a while, and there is an association with someone being overweight or obese. When food is ingested, the insulin is secreted, but because of the obesity, the cells resist the storage of food because the cells are telling the insulin, we're full already. There's no more places for us to be stored. So the body has difficulty finding cells to store any of that food. So it goes back into the liver. The food accumulates in the blood, it stays in the blood longer. And so just like in type 1, where the kidney starts filtering the excess sugar and dilutes it to eliminate it, you'll see additional symptoms where there's skin issues, infections, neuropathy, and vision issues where this sugar is stored in other places in the body. The advantage to type 2 diabetes is that you can adjust your lifestyle, you can increase the cell's ability to store food appropriately, and you can, with weight loss, use the available insulin and lower that blood sugar more effectively. So medications can also help with this, but if lifestyle changes don't produce the positive changes, that the diabetic will eventually have to take insulin. You can also have weight loss surgery that will help with the effectiveness of losing weight quickly, but you will also have to, some people use bariatric surgery as a way to prevent diabetes, but eventually that too will lead to insulin usage over time. Pathogenesis of type 2 diabetes is listed in this slide. It shows the impairs insulin secretion, the absorption of the glucose, the hyperglycemia, the increased basal hepatic glucose production, and the decreased insulin-stimulated glucose uptake. So you'll see hyperglycemia as a result. So let's talk a little bit about gestational diabetes. And this is defined as any degree of glucose intolerance with its onset during pregnancy. These are the latest statistics we have from the CDC. And this is the age of mothers from the age of 2016 to 2021. And every single pregnant woman comes in to be prenatally tested. The first thing they do is a glucose tolerance test. And so they look and see what your risk factors are. But every single person that's average or at high risk for gestational diabetes is going to have a glucose tolerance test. And even those that are low risk will probably have a glucose tolerance test now, because there's so many undiagnosed diabetics in the world. So they probably will just do it just as a routine. But high risk women should be screened at the first prenatal visit through a glucose tolerance test, and then periodic throughout the pregnancy. So who are these high-risk women? So these would be patients who are markedly obese, that have a family history of diabetes, that have a personal history of gestational diabetes in the past, or their mother may have had gestational diabetes, and glycosuria, where they are spilling glucose in the urine. There are also some high-risk ethnic groups, and they should also be tested. Those would be Native Americans, Hispanic Americans, Asian Americans, and Pacific Islanders. Those are specific to these ethnic groups that should be tested. They will be retested again at 24 and somewhere between 24 and 28 weeks gestational age. Your average risk women should also be tested just like the high risk. They'll be tested initially and also again at between 24 and 28 weeks gestation. And who are the low risk women then, you ask? And so those would be any of those people that are not in that ethnic grouping. They would be patients that are younger than 25 years, females that are younger than 25 years. They would be of normal weight before pregnancy. They would have no first degree, like that would be a parent, a sibling, or a child that does not have diabetes, and no history of glucose intolerance in the past, not a member of that high-risk ethnic group, and no history of poor obstetrical outcomes. So in this graphic, you can see that there is the age group. You have 2016 is the light blue, and 2021, which is the most current, in the dark blue. And you can see the progression of gestational diabetes increasing in 2021, and it's gone up, and it gets exponentially higher as the age goes up. So if the age is 40 or above, there are people that do have babies greater than 40 years. People are waiting longer and longer to have babies. You'll see a higher potential for gestational diabetes in that age group. So the rate has increased between 2016 and 2021 from 6% to 8.3% in this group. And I believe that there must be a typo in your book, because I can't see. It says it's 18%. I can't see anywhere in that book where it talks about 18%. So just make sure you double check that. But I don't see where there's 18% of people having gestational diabetes, not even in a global perspective. So initially, about 70 to 85% of these women can manage blood glucose if they're by dietary modification alone. But if that does not maintain blood glucose around 140 to 180, which is the target range during pregnancy for someone who tests high risk, then they'll have to be on insulin. And so after delivery, your blood glucose should normalize. But for these women with diagnosed gestational diabetes, there'll probably be diagnosis or development of type 2 diabetes probably within 3 years or more. So they should be screened for pre-diabetes or type 2 diabetes about every 3 years by their primary care physician. So if you are one of those folks that has that kind of thing, keep that screening in the back of your mind that you would probably need to do that. In the big yellow box in this slide, it shows the glucose tolerance testing. And the normal threshold value for that is 140. And the higher risk would be greater than 140. And so what they do is they have you come in fast, have a normal diet before you come in, and then they'll give you some high glucose and then test your blood sugar periodically through the test. And they'll keep giving you doses and see what your blood sugar is at certain time intervals. So the target range, if you are scoring greater than 140 milligrams per deciliter, you're going to be wanting to keep that range somewhere within 140 and 180. So that's how that glucose tolerance testing works. So now let's talk about diabetes 1.5, which I think is a pretty interesting thing here. In the 1970s, scientists they accidentally stumbled on this phenomenon because they were testing proteins called autoantibodies in the blood for the type 1 diabetic. The presence of those proteins suggested that these patients were attacking their own body's immune system. These antibodies were. And this was the first time that type 1 diabetes was considered autoimmune disease, where the beta cells of the pancreatic islets were destructive. And as an additional part of their study, these scientists looked at similar autoantibodies in the general population, and they compared them with patients with type 2 diabetes, which is not considered an autoimmune disease. And these autoantibodies were also present in about 10% of the type 2 diabetics. So, but they weren't present in the general population. So this suggested that there was this subcategory of LADA having no obvious differences that they could see externally separate from the type 2 diabetic. So that's why they initially diagnosed them as type 2. But the difference with the type 2 is that they were not associated with obesity in any way. And they still had, despite what they were trying to do for treatment, they still had hyperglycemia. So the initial symptoms that these patients present with are severe exhaustion all the time, but especially after meals. So when they eat something, they get completely tired out. Confusion and lightheadedness, feeling hungry after meals. So they're hungry and tired just after eating a meal. Then the symptoms evolve into as the insulin production decreases, because during this time they do have some insulin in their system, and that's why for the initial 6 months after this disease's onset, they don't need insulin. They're not insulin dependent. So there is a gradual decline in insulin production over a period of time for these folks. So they'll start getting symptoms like blurred vision, they'll start getting tingling and painful hands and feet. They'll go into the polydipsia, the frequent drinking of water, and the frequent passing of urine, the polyuria, mainly because of the hyperglycemia. So they'll get these signs and symptoms that kind of intertwine or cross between type 1 and type 2. But the symptoms come on much slower than type 1 diabetes. But when they do come on, they are more aggressive than those of type 2. They're almost always diagnosed in adults between 30 and 50 years of age. And for that final confirmation of a diagnosis of LADA, there has to be an autoimmune etiology, whether it's thyroid disease, rheumatoid arthritis, lupus, Sjogren's, something that's in that autoimmune category. The short-term complications of this syndrome are DKA, and patients really need to know what to do to prevent DKA and how to self-test for ketones if needed. And then the long-term complications, of course, would be the microvascular and macrovascular problems with diabetes overall. What is hard to diagnose in this situation is that the way that it manifests, and if they're not particularly aware of not having that obesity with a typical type 2 diabetic, they're going to not give the patient the right treatment pending, giving them oral anti-diabetics, and those anti-diabetics are not going to help them. So they're absent of this metabolic syndrome, meaning they have normal weight, normal vital signs, normal cholesterol, normal lipids, but they have an autoimmune condition, could be Graves' disease or something. But when they do a GAD or GAD antibody test, there is a positive presence of those antibodies in their system. There's also a C-peptide test, but it is not as conclusive, especially in the early stages. So that GAD antibody test is most conclusive. They can do glucose testing before meals and bedtime, and that's always recommended. And there are ways that researchers are looking to try to halt the progression of LADA before the immune system starts destroying the insulin producing cells of the pancreas or your beta cells. But there's no way to prevent it. Approximately 10% of those patients that have type 2, like I said, suffer from this latent diabetes in adults. So I think it's a very interesting phenomenon, and it's something that you're going to start seeing more and more in your classifications. But be aware that folks that have this do not present in the same light as your typical adult onset diabetic. So this is a new and up and coming finding. And I believe in the 1990s, this was officially became a diagnosis, like 1993. So what are your risk factors for type 1 and type 2? So risk factors are early onset, familial, genetic predisposition, possible immunologic or environmental, which would be your viral or your toxins as those factors. And then your type 2 would be obesity, your age, impaired fasting glucose or impaired glucose tolerance with hypertension. You'll have blood sugars, the hypertensive greater than 140/90, your high density lipoproteins will be less than 35, and your triglycerides will be high, greater than 250, and you'll have possibly a history of gestational diabetes or babies that are over 9 pounds. So the clinical manifestations of diabetes 1 and 2 depend on the level of hyperglycemia. Remember, initially in type 1, you may have this sudden weight loss. And that's pretty unusual because everybody thinks that if you're a diabetic, you're always fat or obese. And so that's not always true. Type 1 diabetes initially starts out with just people just lose weight, but they also have these 3 classic symptoms of polyuria, polydipsia, and polyphagia. They have this fatigue, weakness, vision changes, the tingling and numbness in their hands or feet. They can have dry skin, skin lesions or wounds that are slow to heal, and they can have recurrent infections. They can have vaginal yeast infections. They can have bladder infections, urinary tract infections, mouth infections, current, colds, upper respiratory infections, that type of thing. But it just depends on the level of hyperglycemia, the type of or severity of the polyuria, polydipsia, and polyphagia that you see. Your diagnostic findings will show that there is a fasting blood glucose of 126 or more. And if you're just taking a random glucose, it will exceed 200 milligrams per deciliter. And there is a chart on your 46.2 for additional findings for that. And I'm giving you these charts and these references mainly because those things in your reference book are there for you to, organize in your mind how you want to. There's so many details in some of these things. We could be here for hours going over this stuff when it's right there in your book. So I'm not going to reinvent the wheel here. If there's something new that that I'm going to find in the latest research or information that I have, I will pass it on to you. But for the most part, your information is there in the book in graphs and in charts for you to look at. So let's look at the medical management of diabetes. Main goal is to normalize that insulin activity and blood glucose levels to reduce development of complications. And the biggest thing you do not want is to have someone go into either DKA or some other major episode related to hyperglycemia. The ADA in 2020 recommends that you have hemoglobin A1C less than 7%. Normal folks walking around are looking at some HbA1c somewhere between 4.5 to 6, something like that. So you're looking at keeping that below 7 is pretty good for diabetic management. Diabetes management has these 5 components. You're looking at nutritional therapy, you're looking at exercise, activity, you're looking at glucose monitoring, you're looking at pharmacological therapies, whether it's insulin or new anti-diabetic medications, and you're looking at patient education. And also, I would like to add to that probably some technology in there, because your education has more to do with just doing, knowing how to give insulin shots or knowing how to plan a diet. It's more along the lines of how to effectively control your glucose consistently during the day, all the time. So let's take these a little bit at a time. Your dietary management goals are to control the total calorie intake to attain a reasonable body weight. And if you're already overweight, you know how difficult it is. It's very easy to put it on. It's very difficult to get it off. And so you have to lower your caloric intake and then increase your activity to be able to lose the weight. And that's why some of these injectables that people are taking now, like Ozempic, and so those things help to kickstart some of that weight loss to where some of these severely obese patients can start moving and have that activity to where they can move a little bit better. Control of blood glucose levels, that's very important. If you can maintain where they're finding like a continuous glucose monitoring, if you can find ways to maximize that consistent control instead of having ups and downs of glucose levels throughout the day where you're having hyperglycemia and hypoglycemic events, you're trying to make sure that you have that steady basal rate of a glucose level that will maintain your energy throughout the day. And normalization of lipids and blood pressure to prevent heart disease. So we'll talk about some of those things that happen when you have too much glucose in your cells and what that does when you respond to lipids and how cholesterol and all of that is associated with diabetes, because that's really important. The role of the nurse in dietary management is just about being knowledgeable. Everybody has an opinion about how you should eat, what you should do, and you have to think about the patient. The patient comes from different background. Food is a very social thing. It's a very sacred thing. It is a very can be very religious thing. It is something that is tied with emotion. It is tied with tradition. And there are times when people are going to eat what they want to eat, regardless of their disease process, because it's something that they need to do. They're going to fast during religious holidays. They're going to have to know how to work through some of those situations, because if they can manage it correctly, then they will not have problems with hypoglycemia events that can cause them to pass out and potentially fall and hurt themselves, or hyperglycemia, which will end up having them in the hospital with emergent care. So the main thing is to collaborate and communicate information to the dietitian. If you find out things with your patient that they have special events or things like that, or they have special needs or specific dietary restrictions for whatever reason, they need to know about that so that they can plan with the patient to effectively have a meal plan or menu plans that will help them. If it's portion control, if it is something that they feel like they can't do on their own, there are ways to work around and to provide some support, no matter what level of finance they may find themselves. Physical therapy, on the other hand, that's a different story sometimes, getting people kickstarted. I know that if people are on Medicare, and diabetes sometimes is for folks that are in older age, 50 and up for type 2 diabetics. So there are a lot of things that can be done if they have computer access. They have, for Medicare patients, there is a program called Silver Sneakers where you have free access to gymnasiums or fitness centers. You don't even have to pay a single fee. You can just go in there and join classes. You can also do online classes and things like that that you don't even have to leave your home. You can lift your legs and do chair yoga. You can do whatever. The main thing is to try and get people to move and do it in a normal way, and they don't have to pay anything for that either. Some people like to just walk around their neighborhood. Some people need to have specific shoes fit for their feet. Maybe they have the neuropathy or some problems with their feet. So all these things need to be taken into consideration when you're talking about diet, exercise, and weight management. Some people like to swim, so that may need to, they need to figure out a way. They may need transportation. They need to be in a place where they can use public transport or have someone take them to the pool or to the community center where there is access to a pool. Reinforcing patient understanding is extremely important because a lot of people will want to give short answers saying that they know what they're doing, may have been diabetic for many years. They think they know everything about it, and they may do know a lot about what they're doing, but there's a lot of changes that have been made over the years, a lot of changes, and so they may not know everything. And so this is where supporting them with dietary and nutritional consultations can help out a lot. And then having physical therapy suggestions and exercise suggestions and weight management. So we need to know our resources, and we also need to know that little steps, baby steps, even pharmacists can help explain medications and how they work. If they don't know what they're taking, they don't know why they need to pay attention, why they need to have some glucose tablets, why they need to have a backup for snacks and things of that nature to prevent certain things from happening. Those are where all these folks can also help back up your words with expert opinion as well. So everybody helps out to back up each other. Your word is valuable, and so are theirs. The meal planning changes constantly, and the dietary recommendations change all the time. You hear all kinds of crazy diets out there, and there really is no diabetic diet. The most successful recommendations include practical tips that are not going to cause a lot of expense and hardship, because the harder you make for patients, the more stringent it is, the more likely they're not going to be able to sustain it. If it's a very expensive situation or it's not going to give you good results, they're not going to adhere to it. If they have to eat special foods apart from their family, or they have to be prepared for special foods, and people have to go out of their way to make sure that these foods are prepared specifically for the diabetic, it seems to not be a sustainable situation, because they are then stigmatized as the diabetic. They can't eat this, they can't eat that, they have to have this, they have to have that. Different from everyone else, it sets them apart. So you've got to make sure that those are all things that are taken into consideration. For people living with diabetes and for those trying to prevent type 2 diabetes, healthy eating is important for controlling blood sugar, blood pressure, and cholesterol. And it's also critical for losing and maintaining healthy weight. Including family in this process can be beneficial for everybody, because maybe some of those people in the family want to join you in weight loss or in changing their diet to eat healthier, or making healthier choices in their food. selection. So maintaining that healthy weight for a person living with diabetes is critical to managing that blood sugar and for blood pressure, cholesterol, and preventing complications such as heart disease and stroke. That's always a big concern for the diabetic patient. A target blood sugar range for a person living with diabetes would be somewhere between 70 and 130 milligrams per deciliter before meals and 180 after 2 hours after meals. So there is an expectation that after you eat something, your blood sugar is going to go up. So it's not too alarming to have blood sugar spike above, around 180. That's what we are looking for. But the best thing to do is to check with that healthcare provider for that range that they want you to be in. So, there are some different values that people pass on and want their patients to have, but that's a good target range generally. For a person that's trying to control their blood sugar, carbohydrates that they have to eat are the biggest impact on blood sugar because carbohydrates are basically simple sugars. They're found in fruits and vegetables, grains, and dairy products, and more places than you would even expect. Dietitians can help with learning to count carbs and find the foods that contain them. They're hidden everywhere. Eating a healthier diet can help you feel better in addition to having better blood sugars. The key thing about trying to do weight loss or to not be, singled out as a diabetic is don't skip meals because that just puts you in harm's way. So diabetics need to eat regularly and mainly at the same time or usual eating times during the day. It's very important, especially if they're taking insulin. Caloric requirements and calorie distribution, exchange lists, those kinds of things help a lot. Carbohydrates should be about 50 to 60%. Whole grains should be emphasized. Fat should be about 30% of your daily caloric distribution, limiting those fats to about 10% and less than 300 milligrams of cholesterol. Non-animal sources of protein like beans and grains, they increase the fiber in your diet. And you can also look at that exchange list on table 46.2 in your book. But one of the things that patients can find helpful is to use the plate to divide, use a 9-inch plate and divide it and use that for portion control because when you go out to eat, that they give you this huge amount of food and that you feel like you're required to eat all that food. But if you can get portion control down, it's really helpful. And so chicken, fish, whole grain foods, crackers, cereal, vegetables, especially the kind you put in salads, eating whole fruits instead of drinking fruit juices are a better option. And it gives you more fiber. Using your low fat and non-fat dairy products like milk and yogurt, making big changes in the way you eat seems overwhelming though. And so it may mean that small baby steps are taken. So you can divide that plate in half, fill it with vegetables and fruit, fill it with, gives you room on the other half of the plate to cut that half into quarters. You can have a deck of cards as a portion for your meat, whether it's a piece of fish or a piece of chicken. Limit your red meat. That doesn't mean that you cannot have red meat, but just limit the amount of red meat you have instead of every single meal having red meat down to 1 meal a week or 1 meal a day, something like that. You want to also, limit your starches and grains and potatoes or bread and, try to eat your snacks in between because you're going to need to cover and not get, especially if you're going to do something like mowing the lawn or do something strenuous or exercising, you want to make sure that you're not burning up all your food and then you get into hypoglycemia. You want to also try to enjoy your food. And I know as nurses, I always kid like I eat like an inmate. I eat so fast. You're given 30 minutes to eat your meal, which is horrible. 30 minutes, and you wolf it down, and then you're barely digesting it, and then you're up running around. You barely have time to go to the bathroom, wolf your food down, wash your hands, and get back out there and work. So when you think about it, try to eat, try to chew, and enjoy it. Give your brain the chance to know when your stomach is full. When it comes to seasoning, skip the salt, use herbs and spices. Um, put the butter on the side. It doesn't mean you can't have some, just try to limit it. And when make a list when you go shopping and stick with it. Don't go when you're hungry, because you end up making terrible choices and binge eat while you walk through Costco. So bring your lunch to work instead of eating out. And I know that a lot of you guys bring your food to the work, to your clinicals, because I've seen it, and you guys are eating pretty good. Your patients can do the same. The portion control, though, to me is the key. Eating at restaurants can serve those huge portions, and when you're at home, you can cook a meal and have leftovers. You need to pack those up like right away, so that you don't go back for seconds and thirds. People are going to fall off track all the time. And we as people always concentrate on the negative. We always concentrate on our failures. And it's okay to fall off track. The thing that nurses can do is to coach and to comfort people, because we all fall off track. We all dwell on those setbacks. But as soon as you can, jump back on the program so that you don't get totally derailed from it. It is going to be normal to be discouraged from time to time. Talk to your dietitian, talk to a friend, talk to someone through your program at your church or wherever you work. They can help you tailor diet recommendations to fit your needs, create a plan that's easier for you to follow. YouTube videos, all kinds of things are now available to people. We just have to help them find that information that works for them. There's no food that needs to be avoided entirely. And they don't have to have different food from the rest of their family. Everyone should be able to eat together, and they can really enjoy eating. So I think those days of, here, you're the diabetic, you can only eat this kind of food, that's not the way it works anymore. So I'm glad to see those changes, and I'm hoping that everyone else is glad about it too, because it really is a downer when you can't eat with the rest of your family. So yeah, you can have a bite of something that Aunt Julie made. You can have, fun at a family reunion. You can have a taste of this or a taste of that. You just have to monitor your portion control. And when you have diabetes and you think about how that's going to affect your health, that's going to be your life. So it's one of those things that we have to help people manage through. That's why we're here. So now we're going to get into this glycemic index thing. So I want to make sure you guys understand that glycemic index is a tool, one of many. It is not the end all be all. It has not been, it's not the panacea that people make it out to be. What this thing can help people do that are not used to looking at foods in a way where it talks about sugar and carbs and all of these things, what it seems to do from my perspective, and this is just me, is that it helps them make better choices. So it's the glycemic index describes how much a given food increases blood glucose level compared to the same amount of sugar. So if I was to break down rice bran into sugar, that's what the number amount is. So they rank these foods on a scale from 0 to 100. The low end of the scale is foods that have little effect on blood sugar, and the high end of the scale has foods that have a big effect or add to the sugar content. The 4 guidelines listed on the slide by the bullet points there show how combining certain foods can prevent these rapid spikes in blood sugar. And that's what our goal is, to maintain that basal level of blood sugar. So you don't want this up and down, roller coaster ride of blood sugar numbers. So patients can experiment with these different foods by testing their blood sugar more frequently while they're working through these foods to see what works, because each patient is a little bit different in how they utilize insulin if they have it, and how they adjust their insulin dosage if they need to. Because you see, starchy foods combined with protein slows down absorption and glycemic response. Your raw or whole foods that have lower responses than cooked or chopped or pureed foods, because it takes longer to get into this digestive system. If you've ever eaten a raw diet or raw salads, or chomped on carrots, it takes a minute to chew all that food and get it into your system. Whole fruits rather than juices decreases glycemic response because the fiber in the fruit itself is going to slow their absorption. And then adding food with sugars may produce lower response if it's eaten with food that are more slowly absorbed. So that's just a common sense type of thing. So the basic principles of that healthy eating, the portion control, and counting some of these carbs, and using this glycemic index to pick foods that are lower on that glycemic index, below 55, can help you have a better effect on your spiking of your glucose. But current research is showing that eating a lot of foods that are high on the glycemic index are linked to an increased risk of diabetes and high blood pressure and heart disease. But studies don't consistently show that is necessarily so. And even if you eat foods with lower glycemic index, reduces those risks either. So it has, there's no big correlation with that. So that has not been proven yet. What is helpful, though, is to have use this as a guide to select your food and planning your meals. The glycemic index has variable benefits. It is a tool that will also help not only in planning meals, but it will help you in weight reduction strategies, in helping you lower your blood pressure, lower your cholesterol levels, improve your diabetic management overall to maintain that basal insulin level we talked about, and to lower the risk of that risk of heart and blood vessel diseases. But it also poses some challenges too. And this is why I say it's not a panacea. It doesn't show how single foods versus combinations of food can affect blood sugar differently. It doesn't take into account everything that can affect blood sugar. For example, it doesn't consider how food is prepared. It doesn't tell you how much a person should eat portion-wise. It only measures foods that have a high amount of carbohydrates. So it doesn't include foods that have low carbs or no carbs at all. It doesn't rank foods based on their nutrients. Foods with low glycemic index ranking may be high in calories, sugar, or saturated fats, for example. And it also may be hard for some patients to follow this glycemic index. For example, packaged foods generally don't list the glycemic index on their labels, so it can be hard to estimate it. So you have to have a different kind of, piece of paper or a laminated card like this one that I have on the slide to help you understand what these numbers mean, and what if you picked up a peach, or if you picked up a package of Rice Bran, what that means. But it doesn't really tell you the portions. So basic principles are it. That's the most way, the Mayo Clinic really guides people in some of these informational settings about diet and GI control. And one of the things they talk about is just the portion control and counting those carbs. So that's for you to see. The other dietary concerns have to do with my favorite things: alcohol, sweeteners, and how to read a nutritional label. And we've all heard that alcohol has a bunch of sugar in it. But alcohol does not have to be avoided. I mean, it doesn't mean that if you're a diabetic, you're going to go out there and grab a bottle of Jack Daniels and jump in a hole somewhere and drink it all down. It is not the same thing. It can be used in moderation. It can cause hypoglycemia for those who take insulin. So diabetics should have an alcoholic beverage with food, not on an empty stomach. Thought that was very interesting. They only recommend 1 alcoholic drink per day for women and 2 alcoholic drinks per day for men. Lower calorie drinks should be considered. Mixed drinks and drinks that contain liqueurs and those syrupy drinks should be avoided because they have a higher fat content. So just keep that in mind. This gives you a standard drink. It gives you 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of 80 proof liquor. There are some low-cal wines, and I'm sure there's some low-cal beers and things of that nature too out there. So, but they just need to be aware of using alcohol in terms of moderation only, and to make sure that you're eating something with your alcohol. Many types of sweeteners exist in the world. Very few of them are any good. You might as well just be having regular sugar. Most of them are just regular sugar. And if you look at you look at the sweeteners in the red, every one of them, just about, is a sugar, a modified sugar, a natural sugar. Anything that has syrup, molasses, OSE behind it, anything like that, whether it's plant-based, whether it's bee-based, I don't care what it is, it's a syrup. It is a sugar at its base. And so these would be added sugars to your diet. Honey is great. Blackstrap molasses is great for different reasons. But if you're using agave syrup because it's natural, it is still a sugar when it's all broken down. Same thing with cane syrup. It's cane juice that is boiled down into a syrup, in a concentrated sugar syrup. So you have to be careful when you read labels and you think, well, it's all natural. Yeah, everything's natural. So is digitalis natural, and you're not going to be sucking digitalis down. Things that are natural don't necessarily mean that they're good for you. So in the diabetic world, half of this chart is really not beneficial. So out of all of these things, all of the things that we've learned over the years about artificial sweeteners, which ones do researchers believe is the best for you? And out of all of them, there's only about 3 of them that are really halfway decent. Stevia, it's about midpoint in a way. Allulose is the best. Allulose is made from jackfruit, raisins, figs, and it's on the up and coming thing, but it tastes more like real sugar, and it does not affect you at all. So I highly suggest that you look at that. Look at your sugar alcohols: mannitol, sorbitol, xylitol. All of those things are osmotic diuretics. They're in toothpaste, they're in sugar-free gum, and they do help out in a lot of ways. They're not too bad. And so those things are not so bad. Your monk fruit is right up under there with allulose. That's not too bad either. But there's only about 3 things that are decent. So the rest of these things either have a cross reference like cyclamate, aspartame, those things, saccharin, those things have a close relationship with cancer causing or carcinogens. And they also, the rest of them have some issues with destroying your gut biome. So I would say look up these things very carefully, and then pay attention to the level of added sugars that you put to your diet. And diabetic patients seem to always get thrown the pink packets. And so some of those things are not the greatest things to be putting in their body for one reason or another. And it doesn't necessarily have to do with sugar. It has to do with other situations in their body with the cells. And then getting to the final thing here about the dietary labels. Food labels that state sugar-free or sugarless may still have calories that equal sugar-laden foods. So they can mislead by the types of words or the advertisements and the logos. If you're looking for your glycemic index, sometimes the glycemic index will be not on the nutrition label, but it would be on the front side of the package, and it will have a GI, and then it will have a number on it. So you can see that this particular how to read a nutrition facts label can be used to teach your patients exactly how to read a label, where to start, how to check your calories, how much it is. And then when you look at how much a serving size is, that really is shocking, because a lot of times you'll eat the whole package and then you realize you just ate 6 servings of something because the serving size that's recommended is so small. And that really comes into play when you're like eating chips or something like that. So believe me, I've eaten a lot of servings of chips in my lifetime. So when you're reading these nutrition fact labels, it's very important to kind of get an idea. And this is where having nutritionists or dietitians come in and do a recipe with people, especially in diabetic education classes. They actually can show them how much a portion is, and I think those are really cool exercises. And then when they talk about the portion of meat being about the size of a deck of cards, and if you think about that, that's the size of the palm of your hand. So it gives you a different perspective on how much food you should be eating at a meal, and that starts hitting home very quickly about how much food we actually consume every day, because our portions are really quite large. So exercise is a very important factor in lowering blood sugar. And a lot of times when people have type 2 diabetes or pre-diabetes, they'll say, you need to get out and get some exercise. You need to do something that is going to burn some calories so you can start lowering your blood sugar. And you can actually get on treadmills. I've seen people that have spikes in their blood sugar. They'll get on a treadmill and they'll start working out on a treadmill, walking fast or running, and they'll see that blood sugar go down. And it'll go down, and it will continue to go down over a period of time. And so that exercise actually lowers the blood sugar. It helps in weight loss. It helps with easing their stress, and it helps give them a feeling of well-being. So it's not only for the body, the physical body, but also the mental health of patients. It also lowers cardiovascular risk because it can lower the heart rate. It can also, as you lose weight, can lower your blood pressure as well. So it's very important, though, that you know that you've got to have a little bit of a workup before you start a rigorous exercise program, especially if you are diagnosed diabetic, especially if you have neuropathy in your feet or numbness in your feet. You have to have foot inspections. You may have to get some different tennis shoes or wear socks or something, have padded shoes or diabetic shoes that are specific to your feet that fit snugly so you won't have blisters or cause sores or reddened areas on your feet. Providers should provide this overall evaluation of the exercises they recommend, especially if patients need to start slow and work up to a more rigorous type of regimen. You can do programs that are requiring minimal travel or equipment. resistance training bands, things of that nature that you can take home with you. Walking's always a consideration as long as they have well-fitting shoes and there's a safe environment in which to walk. It's always safe to go to a mall area or something like that inside, where I guess it used to be, but you can go into a mall where they have mall walking periods of time before the stores open, and mall walkers will convene there and walk around the mall area. The other thing about exercise, it helps with your cholesterol and your triglyceride levels, and it does this also by altering the lipoproteins in your body. So that's a really big benefit to exercising. It kind of burns that fat. Unstable diabetics who have blood glucose levels above 250 milligrams per deciliter and who spill ketones in their urine should not start an exercise program until they are stabilized. The snacks should have about 15 grams of carbs. There should be protein snacks available. And blood glucose monitoring should be performed before exercise, especially if people are taking insulin. And type 2 diabetics can benefit greatly from exercise, like I said, and pre-diabetics, they may not need food prior to exercise. It depends on the patient. So it all depends on that person. Some people have Glucerna or some of those drinks in an outside refrigerator or in a cooler so that when they come in, they immediately get one of those drinks, test their blood sugar to see if they need it or if they're starting to feel weak. After doing some yard work or something like that, they have that stashed out in their cooler or in their garage just so they have ready access to something. Glycemic. Even in the older population, physical activity and fitness helps, and it can improve glycemic control, circulation, and quality of life. And because there's a risk for many comorbidities, especially related to the heart and the lungs, primary care providers should evaluate prior to any start of any exercise. And this is also important if they have balance issues or joint disease, which a lot of older adults have arthritis or joint disease issues and balance issues. So physical therapy programs, that medical silver sneaker program, and other community outreach programs give them a social outreach and interaction that help mental health and prevent loneliness and isolation as well. So look at chart 46.5 on the general exercise considerations. Make sure that you realize that you need to monitor blood glucose levels before and after. Sometimes, depending on how rigid their insulin control needs to be, and that they make sure they have access to snacks, and then age considerations for the elderly. Make sure you understand about the gerontological considerations. So now we get into insulin therapy. There's a variety of insulin preparations available today. They each have different characteristics, and there is a table 46.3 that goes through each in detail. We'll talk about the rapid acting, short acting, and intermediate acting. The blood glucose monitoring part of diabetes is the mainstay of diabetic management, and self-monitoring of blood glucose has dramatically altered diabetes care, because the main thing that we try to do is to ensure that patients know how to do their own blood glucose checks, and that they know how to draw up their own insulin, and then they know how to check their insulin, store their insulin, and dispose of their supplies, and where to inject the insulin. And it's very important that they know all of those things, because they won't have any difficulties with insulin therapy. So rapid acting insulin is rapid onset and short duration. It basically acts as a tie-over, so a longer acting insulin can be administered. The one thing about this is that patients should not eat 5 to 15 minutes after that administration, because it's such a quick acting thing that their blood sugar will go way up if they don't eat during that period of time. The short-acting insulin is usually given 15 minutes before a meal alone or with a longer-acting insulin. Your intermittent insulin is your MPH. This is around 1 to 1.5 hours onset and peaks around 4 hours. This is your cloudy, milky insulin. Patients should eat around those onset and peak hours. And then your long-acting insulin is very slow onset. It's basically like a basal type of thing. It doesn't have a peak to it at all. And you usually give this once every 24 hours. And this just serves as your basal rate. It just keeps an even level of insulin through your body. Insulin regimens can vary. There's two approaches to insulin therapy, and it can be a very conventional or simple process, or it can be intensive. And so that table 46.4 describes different regimens and the advantages and disadvantages of each. But these are types of things that you need to consider depending on the type of patient you're caring for. The insulin regimens, they combine short-acting insulin and longer-acting insulin. The two general approaches are, when I talk about the simple process or the conventional, this is for somebody who is frail, somebody who does not get out very often, who has very limited activity, whose self-care abilities is limited, or they just don't want to participate. They just don't. And they don't want to manage their own care, or they can't manage their own care. Injections of insulins are combined to cover structured times between meals and snacks and before bedtime. So it's a very simple thing. It's just if they want to combine those, like short and long acting or short and intermediate acting, they will do so that they can combine those injections and not have so many. The intensive, more complex process is when you need really tight glucose control. And it's a more complex process. It's very detailed. These would be in cases where you have patients that have had a kidney transplant. They've had this problem with hypoglycemia, and they really need to watch how they give this insulin, where, when they give it, what types of foods. They're really monitoring carefully the type of insulin and when they're giving it. If these patients have irreversible diabetic damage like blindness or kidney disease, if they have CNS disorders, if they've gotten cardiac or cerebrovascular disease, like if they've had an MI or a stroke and they're severely debilitated, and they're, sometimes after a stroke or an MI, diabetes can be really hard to manage. And so the difficulties there require a very tight control over their glucose. So that monitoring has to be very, very strict and stringent. And then if they have ineffective self-care skills altogether, you have to monitor them very carefully. Some of the complications of insulin therapy, it would seem to be the same as any medication that you give someone: local allergic reactions, systemic allergic reactions. The local allergic reactions, people have to have insulin and they have a localized allergic reaction. There's very few choices. Insulin pretty much is insulin. You got to have it to survive. So you may get redness, swelling, and tenderness about 1 to 2 hours after an injection. It can resolve in hours or days, but if it does not, they may need to change the brand or the type, or they report the lot number or whatever. But it's going to have to be, some way of being able to sensitize the patient to that insulin. The systemic allergic reaction, that can cause anaphylaxis. They may need a more rapid way to desensitize the patient, where they give small microdoses of insulin and gradually increase those doses over time. And this is extremely rare that you would have a systemic allergic reaction. And this is where you would call in an allergic specialist, someone that would know how to monitor those, doses to watch for anaphylaxis. Insulin lipodystrophy, this is where you know that your patient is not rotating sites for giving their sub-Q injections. This causes, if they keep giving their insulin in the same spot all the time, you'll end up with a loss of sub-Q tissue in that space. It'll form some fatty scarring tissue. The result of that, if they continue to keep injecting into that same spot, is that you'll have a less than adequate absorption of the insulin into their system. And so it's just, it's not a very good thing to have. So they need to be taught, patients need to be taught how to rotate and where to rotate to. And there's plenty of places on your body that you can give injections. The resistance to injected insulin. Immune antibodies can develop over time, causing the patient to need larger and larger doses of insulin and to control their diabetic symptoms. And there is an insulin called U500 that is specifically ordered. It's very concentrated, high dose of insulin, and they may also combine that with corticosteroids to confront those antibodies and allow for the reduction of the dose. U500 has to be stored separately from any other type of insulin, because if you don't do that, especially in a hospitalized situation, you can risk having an overdose of insulin. It can be mistaken for the regular U100s or the other types of insulin. But U500 is got to be stored away from the other insulins. Morning hyperglycemia, there's a chart on 46.5. There can be a gradual rise in blood sugar in the morning. And if this occurs, there may need to be an adjustment of the evening dose of insulin or the last meal dose of insulin that may need to be increased. Some OG effect can result in early morning hypoglycemia. And then at that hypoglycemia, then all of a sudden there's an increase in blood sugar that when other hormones kick in. And so they may need to increase the bedtime snack or decrease the evening dose of insulin in those cases. So everybody gets sick of doing injections. Everybody gets sick of doing blood glucose checks where you stick your finger all the time. Everybody's getting sick of that, especially the higher number of patients having diabetes. That's the one big drawback of all of this, is being stuck all the time. And I can only imagine. I watched my father do this every morning, have his blood pressure checked every morning, and his fingers always were sore. And I can only imagine just how that must be, day in, day out, multiple times a day, having to check your blood sugar and get poked with a needle every single day. So the biggest drawback is this patient satisfaction is just this having to check your blood sugar all the time. And you know you have to do it, so you do it and you get over it, but it's still just unbelievably painful to deal with that every single time you turn around. So here comes innovation, and thank God for it, because we're getting different ways of being able to decrease med errors and also increase ease and delivery of insulin to the patient. And so that comes through, of course, you can have your traditional subcutaneous injections, which we've all gone through our clinical rotations. We've been able to do our skills labs where we've done sub-Q injections, and we've studied where to do our sub-Q injections and been tested on that. Our insulin pens are out there now with, they've already been preloaded. You have jet injectors that actually help load and like basically spring load the insulin into the body. You've got insulin pumps that can be worn outside the body and have a little cassette that pumps insulin in, and you can have continuous glucose monitoring, which does not deliver insulin, but it helps with a continuous glucose monitoring device that is implanted into the back of the arm or wherever the patient wants it, that is suitable for that based on the manufacturer. And they can use their cell phone, smartphone to read their blood sugar at any time. And that way they can have a rapid readout on without having to poke their finger. They know exactly what their blood sugar is, and they can get their insulin ready to go. So the key to that better management is access to this technology and affordability, insurability, and provider advocacy. It's very painful to have a doctor give you a free insulin monitoring device or insulin pens or samples, and then your insurance doesn't cover it, and then you have to foot the bill for it. So it's very wise to make sure that patients know that they have to be able to see if their insurance will cover and what kind of insulin their insurance will cover before they get into samples and all the things that go along with that. Sometimes the discomfort from the hospital systems to use the newer patient-driven technology can be a barrier, and that's where this continuous glucose monitoring comes in, because the future is there, especially in short stay situations like ambulatory care centers, where you go in and these people have glucose monitoring. They may want to continue to use, if they're only in there for, like, say, a cataract surgery, or they're in there for a very short period of time, they may want to use their monitoring devices rather than use the point of care testing. Inpatient facilities may differ. It depends on, who's running that regulatory process. There are some situations where the hospital system must use point of care testing, and all glucose monitoring devices have to be the same. And that is meant for a lot of different reasons. Number one, it maintains the type of certification that the lab requires for point of care testing for the state and for the certification of that lab. It also ensures that every single person that is checked to or eligible to test patients has the proper training and receives that training annually as prescribed, and that they are doing quality control checks routinely every day as prescribed by the manufacturer, and that the proper cleaning and infection prevention instructions are maintained and carried out throughout the organization regularly. And so all of those things are meant to standardize and streamline that process. So having so many different types of monitoring devices come into the system is very difficult, and you don't know if they're always accurate. So we don't know what that looks like. So a lot of times hospitals will not allow for patients to bring in their own glucose monitoring. On the other hand, they will allow patients to come in with their insulin pumps. And there are policies and procedures for utilizing insulin pumps and having them checked to see if they're patent, working, and everything is functioning. But insulin pumps maintain that continuous basal rate of insulin, and they still will have the hospital-based point of care testing to check their blood sugars. So it's really important. And if the patient wants to double check their blood glucose to see if their particular machine is correct, that's up to them to be able to do that. But the hospital is required to use, especially inpatient facilities are required to use their own point of care testing to document those blood glucose findings. Insulin pumps, you can also use IV pumps that are specific to setting up an insulin drips, but insulin pumps are different than that. Those are things that are little small cassette loaded devices that are preloaded and set for prescription based on the doctor's orders. So the future is to have implantable insulin pumps, and so we'll see how that goes. But coming from a surgery background, some of these things are problematic because they can be dislodged, and patients can get a big rapid dose of insulin if the tubing or the implantable becomes dislodged, or even you could get less insulin in hyperglycemia if that implantable tubing becomes kinked or whatever, or blocked. So there are some pros and cons to using some of these different devices, but just to let you know, there are a variety of things insulin delivery, and it's important for us to understand how to use them properly. And if those patients go home with insulin pens or jet injectors or an insulin pump, it's important that patients know how to use them. If they have to do subcutaneous injections the traditional way, we have to do teach back and make sure that they know how to do their own injections. So part of that education and self-management is the different types of insulins that they will be required to take, the symptoms of hypoglycemia and hyperglycemia. If they get into a situation where they need to come to the emergency room, what's required for emergent care, blood glucose monitoring, injection of insulin, the insulin pump use, and then the use of those continuous glucose monitoring systems and how that works. So here we go with question number 1. If you know what category of insulin is rapid acting, the answer is A, aspart. It's rapid acting. Regular is a short acting insulin, and pH is intermediate, and glargine is long acting. So let's talk a little bit about oral anti-diabetic agents. There's lots of them now. And there's a few things that we've noticed specifically on the med-surg floor where we're doing clinicals. We've seen an uptick in some issues. And one thing that came to my mind is somebody asked me why we were having Fournier's gangrene. And I don't know if this particularly works with this patient, but the SGL2 inhibitors, which would be your dapagliflozin, canagliflozin, empagliflozin, or tugliflozin, there is a warning for increased risk of developing Fournier gangrene, urinary tract infections, and euglycemic ketoacidosis, and we'll talk about that in the following slides. So you have to be careful with some of these things. There are black box warnings on some of these. That means that there are some serious side effects that are related to these medications. So you need to be aware and make sure your patient is aware of some of these warnings. So when you look at the day of surgery recommendation, I just want you to forget about those, that column, because this is for ambulatory surgery patients. This is an anesthesia guide that we used explicitly for surgery, and when to tell patients to hold their medications, or when to take their medications, or to continue, or whatever, how many days out. So you can use that if you want to as your own personal guide, but basically you can see from the top to the bottom which is your most common. Metformin remains to be the most common. It's the most, actually it is really the most inexpensive type of medication there, but it does cause some nausea and I believe some diarrhea, and it is contraindicated with people with some renal problems, so you have to be careful with that. But the mechanism of action and the typical doses and things are the big things we want to look at here, and the way that these different drugs work. You'll have some of these drugs where you're using 2 different kinds of oral anti-diabetics. You'll have some of these that are very interesting in the fact that if one doesn't work, they'll add the next level, sulfonylureas, your different DPP4 inhibitors, different things like that. That depends on the level and why your pancreas aren't working well, or why you're having problems. So I think the way that these drugs are just prescribed depends on how the blood sugar is working, or how the insulin production is working, or if there's a resistance to certain things. So when you think about how that person individually is responding or showing symptoms of the diabetes, you're going to be looking at why that doctor prescribed this particular drug class. So just want you to know about these drugs, these warnings on here, and some of the, side effects that can be somewhat unpleasant. And so just take a look at those. When you look at the sites of action of the oral antidiabetic agents, you look at the liver, you look at the pancreas, you look at the muscles, the fat, and glucose absorption in the intestines. So, and the way that those drugs work tells you the biguanides, the thiazolidinones work with the liver, amylin analogs, incretins, your insulin, secretagogues, incretins work with the pancreas, your glucosidase inhibitors, amylin analogs work with your intestines, as well as your thiazolidinones. I'm sorry, I'm massacring these names. Work more with your, and your biguanides work with your muscles. So just look at the major effect and minor effect with the red and the green arrows. And this is specific with your type 2 diabetic patients. And you can see just kind of how those things work. I thought this was pretty interesting. So let's talk about the acute complications of diabetes. This would be hypoglycemia, DKA, hyperglycemic hyperosmolar syndrome, or HSS, and the comparison of DKA and HSS, which is residing currently in that table 46.7. But I also formed one for you as well on this particular presentation. Whether you're diabetic or not, I'm sure that some of you all have experienced hypoglycemia, where you've had this feeling of sweating, tremors, tachycardia, palpitations, nervousness, and hunger, where you just start just feeling disoriented, or you just feel like very jittery. And this is usually because there's too much insulin, or you've had too much activity and not enough food. You have those adrenergic symptoms like I talked about. Your central nervous systems may display your inability to concentrate, have a headache, confusion, memory lapses, slurred speech, drowsiness. I know that that's what you're having right now while you're listening to this. So go get yourself a snack while we're listening to this presentation. But this is part of not having enough blood sugar, not having enough energy. Severe hypoglycemia can lead to disorientation, seizures, loss of consciousness, and death. So there has always got to be some semblance of balance when it comes to blood sugar and your electrolytes. So the management of hypoglycemia is this, and this was one of the questions that I saw on some tests when we were doing some run-throughs of some practice test things. So it's like, what do you do when you're giving someone, somebody has a hypoglycemic attack? So you give them 15 grams of fast-acting concentrated carbohydrate. Well, what is that? Well, if you have glucose tablets hanging around, which, sometimes people have those, you can give them 3 or 4 of those, or you can just grab them 4 ounces of juice. Well, Becky, I thought you said we were supposed to just eat real fruit and not have juice. Well, have some juice around, or just get a regular Coke or Pepsi or Sprite. Have some regular soda around, not diet. Diet does not work. So you need to have, when you're trying to get blood sugar up, you need real sugar. You retest the blood sugar in about 15 minutes. If your blood sugar remains around 70, or if symptoms persist, give them a snack with some protein and carbohydrates. So you can give them some peanut butter and a cracker. Give them a little bit of milk. Carbohydrate, unless their patient plans to eat a meal within 30 to 60 minutes. But you want to get that back up a little bit. So it's gradual. One thing that I know that all diabetics need to be aware of is they have to be prepared, because they're going to have one of these episodes. They're going to get out and they're going to do something. They're going to skip a meal. They're going to do something that they went back into their normal way of life, and they forgot that they were diabetic for a minute. And they're going to forget to eat, or they're going to start working in the yard, and they're going to get sweaty and hot, and they've mowed the whole front 40, and they forgot, and they feel like they're going to pass out. They need to have a preparation nearby. They need to have their cell phone handy if they're going to be out there in the yard. They need to be able, not doing it all by themselves, but have somebody at the house with them that's going to be available to them if they fall out or if they have one of these hypoglycemic attacks. They've got to be aware and prepared. And this is why sometimes those continuous glucose monitoring devices are so nice, because if they start feeling a little bit funny, they can just reach around, put their smartphone on that device and see, hey, my blood sugar's 70. I need to go in and get myself a drink and sit down for a minute. So it's really important that patients know what their symptoms feel like and have some of these things available to them: crackers, snacks, glucose tablets, glucerna, juice, sodas, whatever they need to have, just in case for that. It's almost like a to-go bag, an emergency bag. They need to have a stash of snacks or something. Some kind of snack with protein, have some peanut butter crackers, something out there to be able to eat quickly. If the patient that cannot swallow, or if they lose consciousness, of course, you're going to call for emergency management to come, but they're going to give them some glucagon. They can give it sub-Q or IM, and they can also give them some dextrose in an IV solution. And there is a Bristojet or a syringe that has about 50 mils of D50, which is your concentrated dextrose solution that can go into IV. And that will get your blood sugar up really quickly. This happens a lot for women also in labor. When they start getting tired out, you may see women receive a dose of D50 in their IV, and you'll see them perk up almost immediately and get some energy to finish delivering the baby. It's uncanny. Let's talk about diabetes, the DKA, diabetic ketoacidosis. This is a very serious thing, and this is one of the big complications of hyperglycemia with ketone spillage, when they start burning fat and proteins. So it's not only just burning, it's burning everything that they can burn. The reason for it is that there is an inadequate amount of insulin. And so you're not metabolizing your carbohydrates, proteins, and fats properly. And this is a life-threatening condition, and it can happen in both type 1 and type 2 diabetics. And as we know, insulin regulates blood glucose levels, especially in response to elevated blood glucose levels. It causes glucose to enter the cells to be used for energy, causing a decrease in blood glucose or a hypoglycemic effect. But in diabetes, not enough insulin is released, or the insulin is resisted, and as a result, insufficient glucose is not entering the cells. and as a result, ketosis occurs. Well, what is ketosis? Well, ketosis is the breakdown of fats for energy. And one of the waste products from this reaction is ketones, which is produced too quickly, can accumulate and cause diabetic ketoacidosis or DKA. In most cases, there is some underlying precipitant which is causing this to happen. There's a pre-existing diagnosis of diabetes already there, but something else is messing with this person. They could be sick. They could have had the flu. They could have been throwing up. They could have, anorexia because they've been sick with the flu. They could have an infection somewhere. They could have misdiagnosed or missed a meal, or they could have missed a dose of insulin, or they could have miscalculated the dose of insulin that they were required to have. Or they could actually be undiagnosed or untreated diabetics. There's several reasons why it can occur, with the result being insufficient glucose being available. So you have those low levels of administered insulin. If the patient's not receiving the proper amount, maybe they have an insulin pump and the pump is occluded. Something's not working well. Or sometimes when they're sick, they have a lack of appetite, and the release of other glucose regulating hormones causes blood glucose levels to be more difficult to manage. Those are those counter-regulatory hormones. You get cortisol, catecholamines, those types of things, and the glucagon. In pregnancies, especially if you have excessive emesis, it can result in malnourishment of the mother, which can result in the excessive production of ketones due to using fats as the main energy source. Excessive and prolonged use of alcohol can result in DKA due to the same malnourishment. Physical trauma or injury, being in a traumatic situation, increases the release of hormones such as cortisol, glucagon, epinephrine, norepinephrine, the growth hormone. Those all increase blood glucose levels. So the scenarios for that would be an MI, pulmonary embolus, stroke, kidney injury, pancreatitis, seizure, thyroid abnormality, GI hemorrhage. Some medications can cause it, like corticosteroids, oral anti-diabetic agents that can cause DKA, even some anti-diabetic agents used in type 2 diabetes. Toxic ingestion of something. Additionally, some patients that are newly diagnosed or not truly accepting their new diagnosis may not truly understand the way insulin works, and so they may need more time to adjust to managing and balancing the dosing, and so they may not remember to take a dose of their insulin. So getting to that root cause of the DK episode versus especially some younger patients may need further counseling and education after this emergent situation is corrected. So incomes assessment, this is the big deal. Once again, when we talked about this the last time, you have to look at your patient. What do you see? What do you hear? What do you smell? What do you feel? Use your senses to help you before you even lay hands on this patient. This patient may come from the ED, which most likely they do, and then they'll probably end up in the ICU for close monitoring and corrective treatment. So this is a very big situation because they're going to need continuous EKG monitoring for electrolyte imbalances specific to potassium for arrhythmias. Remember, DKA is not always related to a high blood sugar. When DKA develops with normal or near normal blood sugar, it's referred to as euglycemic DKA. And it's important to recognize because it is associated with this euglycemic DKA has a higher mortality rate. It can occur in the presence of exhausted glycogen stores in the liver. And that's usually from protracted vomiting or long-term vomiting over and over, alcohol use that is chronic, malnutrition, those things cause it. An increasingly recognized cause of glycemic DKA is from these SGL2 inhibitors. Currently, there's about 4 of those. That's your Jardiance, Invokana, Farxiga, and Steglatro. And I know I gave you the longer names for that. That's anything with the flozin at the end of it. Empagliflozin, canagliflozin, dapagliflozin, or ertugliflozin. Those are all the things. But Jardiance, you know that one. Invokana, you've heard about that one, I'm sure. Farxiga, I'm sure you've heard about that one. Farxiga, I'm sure you've heard about it. Those are all the ones that can cause this euglycemic DKA that has a higher mortality rate associated to it. So the nurse is going to be monitoring hourly or more frequently vital signs. You're going to be looking for hypotension and tachycardia. You're going to be looking at the lung sounds, breath sounds. You're going to be listening to this difficult breathing pattern, Kussmaul's, which is a deep sighing type of respiration. You're compensating. Patient is compensating. You have ABGs that have a low bicarb, a low pH, a low PCO2. It's a metabolic acidosis with respiratory compensation. That patient is breathing hard, breathing like fast, and breathing deep and sighing with each one, mainly because they're trying to breathe off these ketones. Because they're breathing off these ketones, they're going to smell like they're breathing juicy fruit gum. And sometimes people say it smells kind of like alcohol, like you've had alcoholic drink. Some people that may have this DKA sometimes are diabetics with DKA. They get mistaken for being an alcohol intoxication because they also have some lethargic situations or LOC changes. So sometimes these patients can get mistaken for being alcoholic or intoxication, public drunk. They can also have nausea, vomiting, abdominal pain, blurred vision, headache, or weakness. They are spilling ketone bodies. They have ketone in their blood and they have ketones in their urine. They have an extreme dehydration. And because of this dehydration, it leads to electrolyte imbalance. So you're going to see an increase in the creatinine, the potassium, and you're going to see an increase in the BUN. If you need to do a Glasgow Coma Scale screening, mainly because you want to see where they are. The first thing you're going to need is to get them hydrated. You're going to need to look at their electrolytes before you ever give them insulin. And the reason why is because if you give insulin before you give the potassium, if they're depleted, you're going to cause catastrophic problems. So let's look at that so I can tell you what to do here. So the first thing you're going to do is you're going to rehydrate with IV fluids. And remember that when you rehydrate, you're going to increase that plasma volume. And you're going to probably have a decreased potassium. And when you give that insulin before you check their potassium level, it's going to enhance that movement from the potassium into the cell. So you have to make sure that you treat that potassium before you give insulin. And that's the one caveat I have here. So let's talk a little bit about the fluid resuscitation, because as soon as you assess this patient, fluid resuscitation should be underway. You probably are going to be having a couple IVs started. Hopefully you'll have a central line started because you need to probably give some high doses of potassium. You know, you could have patients that are normothermic and they still are infected with something, so you can't always tell. Diabetes complicates some of these symptoms. So while getting to the bottom of that cause, you're going to be doing this fluid resuscitation. That fluid, giving that fluid increases the intravascular volume. It reduces insulin resistance by decreasing the counter-regulatory hormones. We talked about those, right? Cortisol, your growth hormone. You got another hormone. What was it? Go back. Catecholamines, cortisol, glucagon. And then you'll be looking at improving that kidney perfusion with that extra volume, because your sugar has caused, you could have an elevated sugar sometimes or not, but you could have that really syrupy like concentration. Additionally, that glucose and water are biochemically linked, and they are osmotically drawn across the cell membranes together. And if you don't get adequate fluids into the patient before you start that insulin therapy, the insulin will continue to draw that glucose and water out of the intravascular space and cause further volume depletion and potential circulatory collapse. So you may think that some of these fluid amounts are excessive, but in DKA patients that are already dehydrated, the typical water deficit is 100 milliliters per kilogram. So, for example, if you had a 70-kilogram patient, they can have a 7-liter fluid deficit. So diagnosis, fluids, check your potassium levels, then you can start your insulin infusion. It's got to go in that order to prevent catastrophe. So you're going to start with a fluid bolus of isotonic crystalloid. Some prefer 0.9% normal saline. Some are leaning more towards a balanced solution of lactated ringers. Noted that lactated ringers has a small amount of potassium in it. Note that there is no dextrose in these fluids. You're going to start with 20 milliliters per kilogram within the first hour, with reassessment of the intravascular status after that initial bolus. Subsequent boluses can be indicated, but there has to be care not to be overly aggressive and throw them in overload with heart failure or pulmonary edema, especially if they're having any kind of kidney disease problems. Once the patient reaches a euvolemic state, maintenance rate is still a brisk 250 cc's per hour, milliliters per hour. So those three things, your fluid resuscitation, your insulin therapy, your electrolyte monitoring, those are your three focus areas. And then you're going to continue to monitor until they reach a normalcy. The choice of fluid composition depends on the patient's serum sodium and other electrolyte imbalances. You can add dextrose to the IV fluids when your patient's blood glucose reaches 250 milligrams per deciliter. In the electrolyte situation, you're going to be monitoring every 2 hours your blood glucose every hour, though. So electrolytes every 2, blood sugar at the bedside, point of care testing every hour. You have to do a potassium replacement to get serum levels between 3.5 to 5.5 milliequivalents per liter. The maximum replacement would be 40 milliequivalents per hour via a central line, and always with cardiac monitoring. If the patient is hypokalemic, you would need to replace potassium before the insulin is started, like I said. The recommended peripheral IV dose, though, has got to be much lower than 40 or you'll burn your IV out. So to prevent that vein irritation, you would start with an IV dose of about 10 milliequivalent potassium replacement. You could add more, another line to aid in overcoming this limitation if a central line is not present. While this is really a not routine thing, you want to look at your phosphate level. If this patient came through the ED, a lot of these, the rainbow tests would be done. All kinds of tubes would be taken from this patient, as well as urine samples as well. And you'd be able to tell what their phosphate level is. And so phosphate, if it's less than 1 milliequivalent per liter, it prevents, you want to give them a replacement. Given that phosphate prevents rhabdomyolysis or neuromuscular dysfunction, and that is including the respiratory muscle weakness and cardiac dysfunction. So, those are important factors when you're trying to deal with someone who has Kussmaul's respirations, or they could have had an MI. You don't know the underlying cause yet. Magnesium, 1 to 2 grams IV, may also decrease the chance of dysrhythmias and presence of the severe hypokalemia if the patient has it. It can also help with potassium absorption when you're giving those boluses. The glucose goal is to see a decrease, whatever they come in with, from 50 to 100 milligrams per deciliter per hour. So you want to see them decrease a little every hour. And you remember, you're taking a blood glucose every hour. And then, like I said, you're going to add dextrose to your IV when the blood glucose is 250 milligrams per deciliter, because you're giving insulin now. So you're going to be covering it. You're going to start an insulin if your potassium is normal to high, and you want to hold that insulin if your potassium is too low. Your insulin infusion should start at 0.14 units per kilogram per hour. You can co-administer a sub-Q dose of long-acting insulin, and that patient usually is on some kind of long-acting insulin at home, so whatever is ordered. Usually, of course, that glargine is your long-acting, and you can give that to serve as a basal loading dose of insulin if you need to. That is optional. But if you have any questions about that, your book is pretty definitive about it, but I've given you some of the most updated information on DKA here. And if you look at the references at the back of this slide presentation, you can see some of those resources utilized as well. So let's look at the hyperglycemic hyperosmolar syndrome. This is a metabolic disorder where there is an insufficient amount of insulin related to undiagnosed diabetes or those who have type 2 diabetes. Now, this is different than DKA because you have hyperglycemia that's greater than 600 milligrams per deciliter, but you don't have any ketone spillage, all right? Ketosis is minimal or absent because there's enough insulin being produced by the pancreas to prevent the development of ketosis, but there's not enough of it to regulate this elevated glucose. This syndrome occurs most often in people that are 50 to 70 years of age. It can also be traced back to acute events like infection, MI, or stroke. Medications that exacerbate hyperglycemia would be corticosteroids, thiazides, diuretics, phenytoin, beta blockers, and calcium channel blockers. Even treatments like dialysis can cause this. Patients usually have had days or weeks of polyuria, polydipsia. They've been able to drink, they've been able to pee, they've been able to tolerate that okay, but because they can tolerate that urinary frequency and thirst, they usually wait too late to seek medical attention until they've gotten symptoms that are in the CNS range. They are starting to act funny. Their friend or family member has to intervene and get the patient to seek medical attention. So the treatment modality is very similar to DKA, but the difference here is that you have these very, very high level symptoms here. You have osmotic diuresis, loss of water and electrolytes. They are very hyperglycemic, very dehydrated. You have manifestations of hypotension, that profound dehydration, tachycardia, and then you have the neurological signs from the cerebral dehydration, and a very high mortality rate of 40 to 70%. So this is not a good place to be. So just like in the DKA, you're going to rehydrate this patient, resuscitate them with saline or 0.9 saline or 0.45 normal saline, and maybe LR. The dextrose is not in the IV solution until that blood glucose reaches 250 or 300. So they have to decrease that glucose from 600 on down. You're going to check your electrolyte levels. The insulin is less important in this particular syndrome than it was in DKA because there's no ketoacidosis. So a lower dose of insulin is required here. That sounds funny, but that's true. You're going to do strict vital sign assessment. You're going to monitor BP and continuous EKG for arrhythmias. Take your EBGs, breath sounds, mental status, blood glucose checks. Your eyes and nose have to be strict. May have to have catheters, all that kind of stuff. Your lab values have to be reviewed. You remember your main focus in this particular syndrome is going to be on your heart, lung, and kidney function. During this acute phase, it's very easy to overload this patient. So you're going to look for jugular venous distension. You're going to monitor this patient every day for weight gain, and you're going to monitor them for heart failure. So when we look at the diagnostic criteria for DKA and HHS, you're going to see the differences. Plasma glucose level is greater than 600 in HHS. You're going to see that there is acidosis in both of these levels. You're going to see the bicarb is a little higher in HHS. You're going to see that there's no ketone spillage. The osmolality is higher, greater than 320, because of this severe dehydration. And your anion gap is variable, and your mental status can go from stupor to coma. So it is very similar to severe DKA, but has a striking difference in the fact that you don't have the ketone spillage. So I added this slide to help structure the diagnostic criteria for both of these serious conditions and to look at the differences between the DKA. You have mild, moderate, and severe, mainly because people will tend to get to healthcare a little bit faster with DKA, more so than with HHS. You try to stay at home and take care of that, and before you realize it, you have gone over the cliff and gotten into some severe dehydration problems. So long-term complications of diabetes. Well, the researchers have continued to try and and tie diabetes to macrovascular disease. And we do have accelerated atherosclerotic changes, coronary artery disease, cerebrovascular disease, and peripheral vascular disease, and limb loss in diabetic patients. But is that macrovascular disease? They have not been able to find a connection. The more appropriate reason would be the microvascular issue, because the microvascular problems with diabetes happen long before diabetes is ever fully diagnosed. The effects of sugar, the effects of the damage to the endothelial linings of the cells causing that thickening and forming that cytokines, and the party at the injured cells, the inflammatory response, damage from the hyperglycemic changes, mainly glycation, oxidation, and glycoxidation. Those all lead to this microvascular problem, causing some of these accelerated atherosclerotic changes. Approximately half of the patients with peripheral neuropathy don't know it. Symptoms can start with tingling, prickly feeling in hands and feet. Progressively, the feet will become numb. They have changes in perception. Their gait and reflexes can occur due to the lack of feeling. It's this diabetic microvascular disease is just it is a major thing. With diabetic retinopathy, you can have this copper type of formation in the blood vessels in the eye, in the back, in the retina. And you can see that. That's why it's so important to have eye exams, because they can look in the back of your eye and see this coppery tinged formation of blood vessels in the back of your eye. Eventually, that will lead to blindness if it goes unchecked and if the blood sugar is not managed properly. The autonomic neuropathy affects your cardiac, GI, and renal systems. The cardiovascular part of it is that it's a painless or ischemia or MI. Like if they have an MI, they don't feel the pain. They don't have the chest pain. They may have mild tachycardia all along. They may have orthostatic hypotension, but interestingly, they will have depression from the heart problems. In the GI system, they can have delayed gastric emptying, constipation, diarrhea, and they can have these vast swings in their blood sugar levels. In the renal system, they tend to have urinary retention due to neurogenic bladder, and then because of that, they can also have frequent UTIs. The typical symptoms of hypoglycemia go unnoticed. The one thing that family and friends report in these patients that have this type of neuropathy, they can get numbness around the mouth or impaired concentration, which leads them to think that something's not quite right with this person. Males can have erectile dysfunction, decreased libido. They can also have UTIs, prostate infections. Females can have decreased libido, vaginal dryness, lack of orgasm, vaginal infections as well. There is a pseudomotor neuropathy, which is a reduction or a decrease in sweating or anhidrosis. This is in the lower extremities, but strangely enough, your body will compensate and increase sweating in the upper extremities. So when we're talking about development of foot ulcers, this has to do with having severely dry feet, which lead to the development of those foot ulcers. So let's talk about these diabetic foot ulcers, which we just can't stand because they're so terrible and they're so hard to heal. When you look at charts 4611 and figure 46.9 in your book, you will see some very interesting illustrations. And then we're about the end of our presentation. These neuropathic ulcers, 50% increase we've seen in lower limb amputations between 2009 and 2015. And letting you know that salvaging lower limbs from amputations, these are preventable if their diabetics are managed properly. Some of the worst diabetic wounds I've ever seen have happened in type 1 diabetics that were younger people. They had such severe neuropathy, they'd be out hiking and they'd get a pebble in their shoe and didn't realize it. And by the time they got back, their shoe was full of blood and their feet were completely denuded. So neuropathy is no joke. It is extremely serious. Foot assessments, foot inspections are extremely important. The proper shoes, taking off your shoes and socks every once in a while, just checking to see if there's any debris in your shoes is extremely important. Neuropathy, peripheral vascular disease, and immune compromise are all big things that lead to lower limb circulatory problems and limb amputations. The foot ulcers begin their journey with a soft tissue injury. And like I said, it could be a pebble, it could be a sharp object, you could step on a Lego, it could be a fissure between the toe or formation of a callus, which is most common. Some people like to put heating pads on their feet. Their feet are cold all the time. So they put a heating pad on, they don't realize that they have it on high, and they burn their feet. Could be a chemical injury due to some kind of caustic treatment, like they're trying to take care of their own callus, and so they put some kind of acid or something on their callus to try to dissolve it, and it ends up burning. You could have a step on a nail, um, have a blister from shoes that don't fit well, um, and that all leads to poor healing. And because their feet are so dry, you can see how cracked and dry the skin is on their feet. There's virtually no skin, like toe prints or skin whorls or anything. It's just very smooth skin. And so these require a podiatrist to, check their feet. If they have calluses, they should not attempt to do anything at a foot salon or nail salon. They should go to a podiatrist to examine and treat pressure areas. They know how to evaluate for neuropathy. They have a little tool that they use that has different size of blunt needles that will evaluate the feeling in their feet, and they can evaluate and assess that neuropathy more appropriately. They can also remove ingrowing toenails, trim toenails, do all of that stuff in their office. And most insurances will cover that, especially if the patient is diabetic. No one wants anyone to lose a foot. What happens with non managed diabetics is you'll start seeing amputations start and just continue to keep going up and up and up, because it is a disease of the microcirculation. And eventually it will continue until it gets to the macro circulation. So the injuries to those small vessels and the larger vessels increase the thickening of those cell walls, and just causes more cholesterol to form and to get caught, which causes more blockages. That's why you have more heart disease. That's why you have more lung disease. That's why you have a lot more problems with the circulatory system, is because of that inflammatory process that goes on. So, in summary, the guidelines for surgery are there. We have very strict guidelines when it comes to bringing patients to surgery and testing patients for blood glucose, especially if they're severely diabetic and they need to be tested during surgery. We have specific guidelines for that. We also have guidelines for what they call enhanced recovery after surgery, where patients are given carbohydrate loaded stuff before that go to surgery. They're not quite as held. Diabetics are usually taken into account, and we try to get them to surgery as quick as possible. If not, we try to give them something by mouth, some kind of carbohydrate drink ahead of time, maybe 2 to 3 hours before surgery, to have that sugar energy there for them. And then we monitor them after surgery as well. Most surgeries, depending on where you have surgery, if they're over 3 to 4 hours, we'll check blood sugars within the surgery suite. If it's not, then they'll have it checked outside. But there are some guidelines in there, and I gave you a reference for the most, I think the Samba guidelines, and those are the most recent in 2024. The goal of that nursing management is to monitor the patients for those extremes and to help them learn how to manage the extremes of hypo and hyperglycemia and to keep them out of that. Hypoglycemia is really important to manage because of the risk to falls. Hypoglycemia leads to people fainting, losing consciousness, and falling, and causing a bump on the head that can lead to bleeding in the brain, and on it goes. Microvascular changes can lead to irreversible sensory changes, leading nurses to assist in patient education on self-management, collaborating with diabetic educators, dietitians, physical therapists, primary care providers, specialists regarding patient progress, how they're doing, how well they want to participate. All of these things help everyone understand how to best have that patient provide care for themselves. You got to get to the root cause of why these things happen, how the patient wants to work with each other, what's the best way to educate them, how to reach them. Assessment of knowledge, regardless of how many years the patient has had diabetes, is important. And the reason I say this is because no matter how long they've had a disease, it's important to know that they have the proper use of equipment. They are updated to the newest technology. They need to know, and it could help change their life. And so those new recommendations could make life so much easier and better for them. And it all depends on the patient. You can show them these new things, and if they're resistant to change, it may be baby steps for them. But I just want you to know that that's part of the nursing thing, is to make people aware of what's new and how it can enhance their life and make their life much easier. So I want to thank you. If you have any questions, you can contact me here at this email address, or you can text me at this number. And here are all the references. Please, take time to look these things up if you're interested. It's it's always a joy for me to hand off things to you that will be helpful for you, especially in your practice area, because I know that diabetes is huge in families, and it's also huge in our patient populations that we see in Med-Surg and in the emergency department. So please enjoy, and we'll see you later. Thank you.